Hello everyone, welcome to Raaonline. So in this session, we are going to learn about a very interesting set of infections, which is the non-tuberculous mycobacterial infections. So as we are all familiar with, the moment we hear the word mycobacterial infections, the first thing that's going to come to our mind is tuberculosis. The second thing that's going to come to our mind is going to be leprosy. But trust me, there are many more clinically significant mycobacteria which are implicated in several infections, commonly pulmonary infections. So let's take a look at this vast group of non-tuberculous mycobacteria. So these are basically organisms which are present in soil and water. They are ubiquitous. Most of these non-tuberculous mycobacteria, they have certain specific environments to which they are endogenous. For instance, if you take Mycobacterium simiae, they are going to be predominantly seen in association with aquifers. If you see Mycobacterium fortuitum, most of the skin and soft tissue infections that occur associated with this organism occurs following exposure to pedicure baths. If you take Mycobacterium immunogenum, this is something that is particularly associated with metalworking fluids. Mycobacterium marinum, as the name itself suggests, is associated with exposure to aquatic and marine environments like fish tanks or swimming pools. Mycobacterium ulcerans is an organism that is predominantly seen in the tropical regions. So major risk factors for non-tuberculous mycobacterial infections are going to be some kind of an immunodeficiency. Now, why do I say this? We all understand that non-tuberculous mycobacteria are ubiquitous in nature. They are present almost everywhere. But despite that, there is an extremely low incidence of non-tuberculous mycobacterial infections, and this tells us that there is some component in our innate immune system which is going to be responsible for fighting against most of these infections most of the time. So whenever that particular system takes a hit, that is when we develop non-tuberculous mycobacterial infections. So if you look at risk factors for developing a systemic non-tuberculous mycobacterial infection, a serious disseminated infection, then usually the host will have some underlying immunodeficiency state. A lot of studies have shown that the CD4 T cells play an important role in conferring immunity against these infections, and therefore whenever there is going to be a deficiency in the CD4 T cell system, then that is going to increase the risk of non-tuberculous mycobacterial infections, for example, HIV infection. Now, when you look at the incidence of pulmonary non-tuberculous mycobacterial infections, which is more common, this is usually associated with some or the other pulmonary epithelial defects. So, mostly seen in patients with bronchiectasis because of some reason or the other. So, generally, we divide the non-tuberculous mycobacteria into two broad groups. We have the slow-growing non-tuberculous mycobacteria, which take usually more than 7 days to grow in the culture medium. And then we have the fast-growing non-tuberculous mycobacteria, which grow within a week in most of the culture medium. Now, as you're able to see, these slow-growing ones are further divided into three different groups. What are they? We have the photochromogenic, scotochromogenic, and the achromogenic. In the first group, the important ones are Kansasi and marinum. Kansasi is associated with a pulmonary disease like tuberculosis. It largely resembles the lung lesions of tuberculosis. Mycobacterium marinum is associated with fish tank granuloma. In the scotochromogenic group, the most important one is Mycobacterium strophylaceum, and as the name suggests, it is going to be implicated in lymphadenitis, particularly among children. Now, you take the third group, the achromogenic group. Here we have two important species. One is the Mycobacterium avium complex, and the other is going to be the Mycobacterium ulcerans. Mycobacterium ulcerans is responsible for the Burley ulcer in tropics, and Mycobacterium avium complex is an important opportunistic pathogen, particularly in patients with HIV. So, it is responsible for causing pulmonary disease. It can cause lymphadenopathy, and it can also cause a disseminated disease, as I mentioned, particularly in those with an immunodeficiency like HIV. And then we have the fast-growing ones. We have the abscesses, chelonae, and fortuitum, three important non-tuberculous mycobacteria which belong to the rapidly growing or the fast-growing group. So, most of these rapidly growing mycobacteria, RGM, most of these are implicated in post-trauma chronic skin and soft tissue infection. So, most often when you have a long-standing abscess or a long-standing non-healing wound, particularly following an injury or following a surgery or a procedure, very likely it is going to be caused by one of these rapidly growing non-tuberculous mycobacteria. Now, let's look at the risk factors a little bit closely. So, as I mentioned, for systemic non-tuberculous mycobacterial infections, usually your host will have one or the other immunodeficiency state like HIV, or they will be on TNF-alpha inhibitor therapy. Sometimes they may have an idiopathic CD4 lymphopenia, or there may be mutations in the interferon gamma IL-12 pathway. Now, pulmonary epithelial defects are going to be responsible for the majority of the pulmonary non-tuberculous mycobacterial infections. So, bronchiectasis, be it idiopathic or be it secondary to cystic fibrosis or primary ciliary dyskinesia, is all going to be an important risk factor for pulmonary non-tuberculous mycobacterial infections. Similarly, pneumoconiosis, COPD, and the various causes of COPD like alpha-1 antitrypsin deficiency is also going to be important risk factors for non-tuberculous mycobacterial pulmonary infections. Another important risk factor is going to be pulmonary alveolar proteinosis, because here there is going to be a defect in the functioning of the alveolar macrophages because of the antibodies which are produced to GM-CSF. As a result, pulmonary alveolar proteinosis is also going to be an important risk factor for pulmonary NTM. So broadly, remember, for systemic or for disseminated NTM, either the patient will have HIV, they will be on some TNF-alpha inhibitor therapy, or there will be some mutation in the interferon gamma or IL-12 pathway. So generally, whenever CD4 is low, either because of HIV or because of other reasons like idiopathic CD4 lymphopenia, patients will be at risk for developing NTM infections. Now, coming to pulmonary NTM, three broad important causes. One is going to be bronchiectasis because of any reason. Second is going to be COPD, again because of any reason. And third is going to be pulmonary alveolar proteinosis. So, three important risk factors for pulmonary NTM infections. Now, coming to the clinical manifestations. So, broadly, we can look at the clinical manifestations from the perspective of disseminated disease, lymph node disease, pulmonary disease, and skin and soft tissue disease. So, broadly, most of the non-tuberculous mycobacteria are going to be causing one or more of these clinical syndromes. So, of this, which do you think is most common? Pulmonary disease is actually the most common. Most concerning, of course, is going to be the disseminated disease. And then, of course, you have lymph node and skin and soft tissue involvement as well. So, cervical lymphadenitis or lymph node disease is something that's going to be more common in children. And skin and soft tissue disease, as we saw earlier, is largely caused by the rapid growing non-tuberculous mycobacteria. And it is commonly seen following some insult to the skin, either traumatic injury or following a surgery or a procedure. So, let's first start by trying to understand about the disseminated non-tuberculous mycobacterial disease. Now, this is the most serious form of non-tuberculous mycobacterial infection and therefore is associated with some form of advanced immunodeficiency. So, this is seen in advanced HIV. In advanced HIV, disseminated NTM is usually caused either by Mycobacterium avium intracellulare complex or by Mycobacterium kansasi. Usually, these patients come to us with a syndrome of a fever, loss of weight, organomegaly, and lymphadenopathy. Mutations in the interferon pathway like IFN-GR1 mutations, this particular mutation is going to be commonly associated with NTM osteomyelitis. So, whenever you find patients with a disseminated NTM disease, particularly with osteomyelitis, keep in mind that you may be dealing with mutations in the interferon gamma pathway. Similarly, defects in the NF-kappa B activation pathway, this is something that is associated uniquely with disseminated NTM infection with tooth and hair abnormalities. So, this kind of a pattern where you have patients who come to you with dental and hair abnormalities and you also find that they have a disseminated NTM infection, always look for defects in the NF-kappa B pathway. Then GATA2 deficiency, this again is uniquely associated with disseminated NTM and myelodysplastic syndrome. Autoantibodies to interferon gamma, this is associated with disseminated NTM infections, particularly in East Asian females. And the most common non-tuberculous mycobacteria in this group, surprisingly, is going to be a rapidly growing mycobacterium, which is Mycobacterium abscessus. Now, as I mentioned earlier, usually these rapidly growing ones are associated with chronic skin and soft tissue infections. They are not commonly implicated in disseminated disease. So, it's very strange that here in patients, in this small subset of patients, particularly in East Asian females, when they do have these autoantibodies to interferon gamma, they develop disseminated infections with a rapid grower, which is Mycobacterium abscessus. And finally, remember Mycobacterium abscessus and fortuitum, again rapid growers, these can be associated with central line or central venous catheters associated bloodstream infection because of contamination from water. So, these are all the different scenarios in which you generally observe a disseminated non-tuberculous mycobacterium disease. So, most important settings, number one, remember in patients with advanced HIV, they can have disseminated non-tuberculous mycobacterial infection. This is one of the important opportunistic infections that should be considered in patients with advanced HIV, particularly when you have patients coming to you with PUO, lymphadenopathy, loss of weight, and hepatosplenomegaly. Second important thing I want you to remember is this syndrome of tooth hair abnormality and patient having disseminated non-tuberculous mycobacterial infection. This is usually associated with a defect in the NF-kappa B pathway. Third is in GATA2 deficiency, you will have disseminated NTM infection and myelodysplastic syndrome. So keep these in mind. Now let's move on to pulmonary disease. As I mentioned earlier, pulmonary disease is actually the most common form of non-tuberculous mycobacterial infections. Now, most patients with a pulmonary NTM, they generally run a chronic indolent course. So often you'll have these patients coming to you with a very long history of several years of throat clearing and nagging cough and fatigue. And you'll find that much later on, after onset of symptoms, they've been diagnosed with pulmonary NTM. In pulmonary NTM, the most important thing is to be able to suspect this particular bacterium so that we are able to send appropriate samples for the required cultures, and we'll be able to make a diagnosis of this infection. Now coming to MAC. MAC is one of the most common causes of pulmonary NTM. Now, Mycobacterium avium intracellulare complex can actually cause two phenotypes of pulmonary non-tuberculous mycobacterial infections. It can cause two phenotypes of pulmonary disease. So, one phenotype is going to be a nodular bronchiectasis, which is predominantly seen in older, taller, thinner women who are predominantly non-smokers, and they have one or more chest wall abnormalities like scoliosis or some pectus abnormality, and associated with that, they often also have mitral valve prolapse. So, this is referred to as Lady Windermere syndrome. The second phenotype is the exact opposite. So, in younger male smokers, it results in a disease which is largely similar to cavitary tuberculosis. It results in an upper lobe cavitary disease. So, keep in mind, MAC is one of the most common causes of pulmonary NTM. Pulmonary disease is the most common manifestation of NTM, and pulmonary MAC can result in two broad manifestations. One is the Lady Windermere syndrome, where you have older, tall, thin, non-smoking females who develop this nodular bronchiectasis, and you find like what we are able to see on this CT here. And you will find that these women also have some chest wall abnormality or some valvular abnormality. The other end of the spectrum is going to be a picture of a tuberculosis, picture of a cavitary tuberculosis. So, upper lobe cavity in younger smoking males. So, these are the two major manifestations of pulmonary MAC disease. Then, Mycobacterium cancersi, as I mentioned earlier, this is something that is going to present with a disease very, very similar to tuberculosis. So, this causes a cavitary lung disease similar to tuberculosis. And finally, Mycobacterium abscessus, this is going to be seen in patients with bronchiectasis secondary to achalasia. So, keep that in mind as well, because as I said, it's not very common that we find rapidly growing mycobacteria causing an infection outside of the skin and soft tissue. So, when you do find these rapid growers in the lungs, in the sputum samples, remember this is usually associated with recurrent episodes of aspiration. So, look for other risk factors for aspiration, like chronic reflux or achalasia or some esophageal dysmotility syndrome. Now, coming to lymph node disease, this is actually the most common manifestation of NTM infections in children. So, in younger children, this is the most common disease. So, in adults, it is going to be pulmonary NTM. In children, it is going to be lymph node disease. Most common cause here again is going to be MAC. Usually, it results in firm but painless cervical lymph node enlargement. Sometimes you may also have local fistulae. One of the most important differential when you have a child with these firm painless lymph nodes is going to be malignancy. So, diagnosis largely relies on histopathology and on culture sensitivity. Finally, coming to skin and soft tissue disease, as I said, usually for a patient to develop non-tuberculous mycobacterial skin and soft tissue infection, there should have occurred some break in the skin. So, usually this follows a trauma or a surgery or a procedure. Usually, patients come to you with painful erythematous subcutaneous nodules, which may be complicated by ulcers or sinuses. So, this again is commonly associated in certain niche settings. So, when they come to you with this clinical picture following a pedicure, particularly with a history of leg shaving just before the pedicure, Usually this is going to be Mycobacterium fortuitum. All these rapidly growing Mycobacterium fortuitum, chelone and abscesses are all associated with outbreaks, particularly in the setting following cosmetic surgeries. So as I said, contamination in the surgical instruments used during cosmetic surgery has been responsible for outbreaks of these non-tuberculous mycobacterial skin and soft tissue infections. So this is AFC. So AFC is your abscesses, fortuitum and chelone, just so that you remember the rapid growers. Then you have the swimming pool or fish tank associated skin and soft tissue infection. So in somebody who frequents a swimming pool or in somebody who manages a fish tank, if they come to you with subcutaneous nodule or an ulcer, you will have to think of the fish tank granuloma, which is caused by Mycobacterium marinum. So here what happens, initially patients develop erythematous swollen subcutaneous nodules. These nodules subsequently can evolve into an ulcer. The clinical course is complicated by tendinitis, and finally they go on to develop granuloma. Sometimes these patients may also have these subcutaneous nodules located all along the lymphatics in their upper limbs, giving us sporotrichoid appearance, because this is something that is usually seen in patients who develop this fungal infection called sporotrichosis, which is commonly seen in gardeners because of cutaneous inoculation of this fungus because of their occupation related risk. Now, these granulomas can also occur around the wrist and can result in carpal tunnel syndrome. So this is typically how a fish tank granuloma occurs. So as you are able to see, this patient initially started off by developing a small nodule in his finger, which then broke down and gave rise to an ulcer that we are able to see here. Then in the tropics, particularly following an insect bite, patient can develop an ulcer. So these painless ulcers are caused by Mycobacterium ulcerans, and this is referred to as Buruli ulcer. Sometimes they can become deeper and they can even result in osteomyelitis. This is generally how the initial Buruli ulcer appears. So all these skin and soft tissue infections are predominantly caused by 3 non-tuberculous mycobacteria. Number 1, you need to remember the rapid growers, AFC abscesses, fortuitum and chelone, usually associated with some contamination of surgical instruments. Second thing you need to remember is going to be Mycobacterium marinum, which is associated with some exposure to aquatic environment. And finally, you will have to remember Mycobacterium ulcerans, which is associated with Buruli ulcer, which generally is seen following insect bites in the tropics. Now moving on to the diagnosis, these organisms can be identified through acid-fast staining or fluorochrome staining of sputum samples or of various body fluids like pus. In the gram stain, they appear as gram-positive beaded rods. Now this is something to remember. Now when you have gram-positive beaded rods, and which are also acid-fast, you have two differentials. It could be either non-tuberculous mycobacteria or nocardia. So if they are going to look more and more filament-like, it's nocardia. If it is less filament-like and more rod-like, then it is going to be non-tuberculous mycobacteria. So remember, both nocardia and non-tuberculous mycobacteria, they are going to be gram-positive and they are going to be acid-fast. So if they are going to be filamentous, it is nocardia. If they are just going to be bacilli, if they are going to be rods, it's going to be non-tuberculous mycobacteria. Now, as I mentioned earlier, you have, based on the culture, you can divide them into two broad groups, the slow-growing ones and the fast-growing ones, or the rapid growers. The slow-growing ones, again, are going to be divided into 3 groups based on the pigment formation. So, if there is pigment formation in light, they are going to be photochromogenic. The important ones, as I mentioned, are going to be Kansasii and Marinum in this group. Now, if there is pigment formation in the dark, it is going to be referred to as scotochromogenic. The important one here is Scrofulaceum. Remember, scoto, scroful. So, both are rhyming. And then you have type 3, which is achromogenic, where there is going to be no pigment formation at all. So here are 2 organisms which are important, which is MAC and Mycobacterium ulcerans. And then of course you have the AFC ones, the fast growing ones, which grow very quickly in the culture medium. Now in addition, there are a few other important characteristics when it comes to their growth in the culture medium, which is going to help us in identification. So one important characteristic is that incubation at 30 degrees Celsius is something that will help us to identify Mycobacterium haemophilum, Mycobacterium marinum and ulcerans. The important ones being ulcerans and marinum. So remember, for ulcerans and for marinum, you already know that both are slow growers. If they are photochromogenic and if they grow well at 30 degrees Celsius, it's going to be marinum. If they are achromogenic and if they grow well at 30 degrees Celsius, very likely it's going to be ulcerans. it could also be hemophilum, because both are going to be achromogenic. Now, of these two, how will you differentiate again? So, hemophilum is something that requires iron supplementation. So, if there is no further growth at 30 degrees Celsius, and if you find that it is achromogenic, then you will add iron, and if there is growth, then you will know it is going to be hemophilum. Now, remember, all these non-tuberculous mycobacteria are an important cause for positive testing in tuberculin skin testing. So, when you do a tuberculin skin testing, you can have a false positivity where the patient need not have tuberculosis but still test positive for the test. One such cause is going to be non-tuberculous mycobacterial infections. So, always remember, when you look at a patient and start working them up for tuberculosis, and you do a TST or comes positive in a patient suspected with tuberculosis, you do an AFB smear. The AFB smear in the sputum is positive, but your gene expert, your expert TB RIF assay, if that is going to be negative, then very likely you're looking at a non-tuberculous mycobacterial infection. So, such individuals, when you send them for mycobacterial culture, it will be able to pick up. Because if it is truly TB, what will happen? Your TST will be positive, your AFB will be positive, and your gene expert will also be positive. So, remember, if TST is positive, AFB smear is positive, but your gene expert is negative, it is very unlikely that such a scenario could happen, because your gene expert may be positive and your sputum smears may be negative. Your sputum AFB may be negative when there is very little bacillary load. That can occur. But gene expert being negative when your sputum AFB smear is positive and TST positive usually tells us that there is non-tuberculous mycobacterial infection. Now, also remember that non-tuberculous mycobacterial infections are an important cause for positive IGRA as well. So, IGRA, again, like tuberculin skin testing, the interferon gamma release assay is a test which is used to assess the immunological response to the tuberculous antigens. So, particularly it tests the immune memory against the ESAT6 and the CFP10 Mycobacterium tuberculosis antigens. Unfortunately, these antigens are also shared by Kansasi, Marinum and Zulgai. Therefore, when you have non-tuberculous mycobacterial infections by any one of these three organisms, then you can have a false positive IGRA as well.